عز عبد الجواد.
خلاص ابتدي يا بيه.
بسم الله الرحمن الرحيم. You are all welcomed in this webinar on hereditary angiolytic edema organized by the Egyptian Society of Pediatric Allergy and Immunology in association with the Pediatric Allergy and Immunology Unit of Ain Shams University. It is sponsored by Takeda and organized by Barcode. Thanks to both of them. It is my pleasure and honor to chair this meeting with my dear student and colleague, Professor Shireen Reda. Professor Shireen Reda is currently the chair of the Pediatric Allergy and Immunology Unit of Ain Shams University. And in the meantime, she is a board member of the society since it was established in 2002. Professor Reda is an eminent international figure in the field of immunology, especially in the field of immune deficiencies. Actually, I'm very happy to be sharing her in organizing this committee. We have 4 distinguished international eminent speakers: Professor Zainab Awad, Professor Ilham Hosni, Professor Dalia Hilmi, and Professor Rasha Hassan Al-Uwaidi. And now I'm going to give the word to Professor Shireen Reda to lead that webinar.
Thank you, my dear professor, for this very nice presentation. To me, I'm really speechless. Professor Yahya Gamal is my professor, and he is the founder of the Pediatric Allergy and Immunology Unit. I am one of his students. I'm really honored to co-chair this session with him. The first speaker here will be Professor Dr. Zainab Awad Al-Sayed, Professor of Pediatrics and Pediatric Allergy and Immunology. She has a lot of work in the field of pediatric allergy and immunology, one of the eminent professors in this field, not only in our country, but worldwide. Professor Zainab Awad is the Vice President of the Egyptian Society of Pediatric Allergy and Immunology. She's member of the World Allergy Organization Board of Directors, Chair of the World Allergy Organization Primary Immune Deficiency Committee, Associate Editor of the World Allergy Organization Journal, member of the Egyptian Pediatric Guideline Committee, and a former president or chair of the Pediatric Allergy and Immunology Unit. If I'm going to talk about Professor Dr. Zainab Awad, I may take 20 minutes to talk about her achievements. She has many publications international, more than 30 publications in the PubMed, and she's going to talk about the epidemiology and classification of angioedema today. تفضلي دكتورة زينب.
Thank you, Professor Shireen. I will share my slides now. I hope everything goes fine. يا رب إن شاء الله كل حاجة تبقى كويسة. Thanks a lot, Professor Shireen, for this presentation, and thanks a lot for Professor El Gamal. It's my honor, dear professors and colleagues. ربنا يسهل يا رب. أيوة الحمد لله. تمام؟ أوكي كده it's fine كده باين كل حاجة؟
أيوة.
تمام. Dear professors and colleagues, it's my pleasure to present today angioedema, the classification and the pathogenesis of angioedema in general. This is an introduction to our theme today, which is on hereditary angioedema. I have no conflicts of interest to declare, and my talk will encompass the definition of angioedema, and we'll try to classify it together to try to understand the pathophysiological mechanisms and the angioedema mimickers or the pseudo-angioedema. By definition, angioedema, it has been previously called neuroangioneurotic edema or Quincke's edema, and by definition, it's abrupt, self-limited, non-pitting, localized, subcutaneous or submucosal swelling due to extravasation of fluid. Which tissue accommodates this fluid? Of course, the loose connective tissue that is present in the eyes, in the lip, in the eyelids, the lips, under submentally in the neck, extremities, and genitalia. It can also have submucosal swelling. This fluid that collects is asymmetrically distributed and is not gravitationally dependent. What does this mean? It means that it doesn't differ when the patient is recumbent or the patient is ambulatory. Not like that of nephrotic syndrome, for example. The angioedema lasts many hours to 3 days, and it leaves the tissues completely normal. It leaves no staining or desquamation. Angioedema can be seen in isolation with urticaria or as a part of a more severe allergic reaction as with anaphylaxis. The main pathogenic mechanism in angioedema is the loss of the vascular integrity, and this is caused by the inflammatory mediator release, whether histamine or bradykinin. This loss of vascular integrity is just increase in the permeability of the blood vessels, and this which vessels are affected are the capillaries and the post-capillary venules. This sketch of the skin, of a cut section of the skin, as we see, this is the epidermis, then the dermis, the subcutaneous tissue, and the muscles. In angioedema, the fluid accumulates in the deeper layers of the dermis. In hives, the edema is much more superficial. Let's see an actual histopathological segment slide here of a patient with angioedema. There is edema here in the deep dermis with dilated vessels. As you can see here, the collagen bundles are dispersed, and there is very few or sparse cellular infiltrates. In the cases of urticaria, the edema is more superficial and there is more cellular infiltrate. Patients with eczema or eczematous dermatitis have the edema fluid inside the cells. This is called intercellular edema or spongiosis. The edema is inside the cell. This is called spongiosis. There are several classifications for the angioedema, whether it's based on the pathophysiology clinically, whether it's associated with urticaria or not, or whether it's on a genetic basis, is it hereditary or not. The most accepted and widely used is that based on the pathophysiology, because if we know what type of angioedema we are dealing with, then we will be able to decide the proper treatment, because not all angioedemas are just treated with antihistamines and that's it. No. We have here the mast cell mediated angioedema and the bradykinin mediated angioedema. The mast cell angioedema, this is a simple figure to show you that the mast cells have on the surface IgE. The entrance of the allergen to which the patient is sensitive will cause cross-linking of IgE molecules with the degranulation of mast cells and the release of mediators. In the bradykinin type or the kininergic angioedema, the high molecular weight kininogen, as we know, it changes to bradykinin under the effect of kallikrein. This step is checked with the C1 inhibitor. If this C1 inhibitor, there's a problem with it, whether it's not present, it's not produced, or it's not active, this will lead to the kallikrein activity will remain unchecked, and there will be accumulation of bradykinin. Then there will be, this bradykinin will act on the bradykinin 2 receptors, will lead to vasodilatation and extravasation. Sorry, I want to ask something here. Is the screen shared here, have my photos and the photos of the others in front of you?
Yeah, I have this, yes.
Is it full screen slide for you?
Full screen, yes.
Okay, thank you. This is a simplification of the classification of angioedema, the histaminergic angioedema, which may be IgE-mediated, as in the case of allergy, or non-IgE-mediated, and it's called pseudoallergy. The bradykininergic angioedema, whether associated with deficiency of C1 inhibitors or with a normal C1 inhibitor. This type of angioedema, the bradykininergic type, both types are either inherited or acquired. Let's go deeper. I'm taking you step by step. Well, we should ask ourselves or ask our patient, is this angioedema associated with wheals of urticaria or not? This will help us decide which type of angioedema. If there are wheels of urticaria, then it might be histaminergic angioedema, and urticaria, if it occurs, the rash appears for less than 6 weeks, this is acute urticaria. But if bouts of the urticaria rash appears for more than 6 weeks, then this is chronic urticaria. The bradykinin type, we have mentioned that it's with the C1 inhibitor reduced or not. Okay, then the fourth type here, which is called IL-1 or cryopyrin. This is seen in patients with periodic fevers. The patients with cryopyrin-associated periodic fever syndrome, this type has urticaria without angioedema. And I want to stress here that the bradykinin type of angioedema is not associated with urticaria. So, the question of whether there is urticaria or not will help me in the decision making. But I should say here that not all histaminergic angioedema is accompanied by urticaria, and we will see this in the next slides. The classification upon whether there is a positive family history of angioedema or not, and we know that the hereditary is autosomal dominant, so it may help me to decide. But sometimes the family history is absent in patients with hereditary angioedema because of new mutations, for example. So this question will help me decide if there is positive family history. Let's take them one by one and see the pathogenesis of each type and some clinical clues to it. The histaminergic or the mast cell angioedema there is wheels together with angioedema, and the angioedema coexists with urticaria in 40 to 50% of the cases. The edema here is the skin overlying it is normal in color, but sometimes it's erythematous in this type especially. What happens with the histaminergic angioedema or the mast cell mediated? This is a mast cell. Many of the stimuli can trigger the mast cell to release its mediators. As we can see here, the regular antigen mechanism binding to the cross-linking the IgE molecules. Maybe it's an autoimmune process with antibodies against the IgE or antibodies against the IgE receptors. Maybe it's physical stimuli like cold or pressure. Maybe it's mediated by complement immune complexes. And maybe it's the toll-like receptor ligands here, especially in patients with infections. The end result is that the mast cell will release the mediators, especially histamine, and this leads to vascular permeability and angioedema. Also, the histamine will act on the nerves, producing pruritus. This is simplified in this diagram here. The histamine will act on the H1 receptors, causing vasodilatation and angioedema. At the same time, the vasodilatation will lead to erythema and urticaria. The histamine can act on the sensory nerves and produce the itching that is seen in patients with urticaria. What are the triggers or the allergens for the allergic type of histaminergic angioedema? The foods, of course, any cause for acute urticaria or chronic urticaria are the same for angioedema. Foods, medications, infections, whether bacterial, for example, streptococcal infection, Coxsackie, Epstein-Barr, schistosoma, fungal infections, also transfusion reactions, and many of you know all these factors. In the case with chronic urticaria, the causes may be spontaneous or autoimmune, or maybe physical, like cold urticaria, cholinergic, and pressure, and so forth. So the causes that trigger histamine release are those for acute and chronic urticaria, but there are still other mechanisms for histamine release. Simply just direct release. Opiates, for example, and the radiocontrast media directly induce release of mediators from the mast cell. In this form of histaminergic angioedema, that is the direct release type, there is urticaria also, because histamine here is the main player. So there will be urticaria. But here the mechanism does not involve IgE because it's direct release. With non-steroidal anti-inflammatory drugs, the patient may have urticaria or angioedema. And this occurs through two mechanisms, either a regular allergic mechanism, and this will be specific for a certain non-steroidal anti-inflammatory drug. The patient will react only to this drug. another mechanism, which is a pharmacologic effect, where the non-steroidal anti-inflammatory drugs inhibit the cyclooxygenase 1 within the mast cells. So this is another way which is not IgE mediated. Let's see, where is the COX-1, where does it act? The COX-1 or the cyclooxygenase 1 helps the change of arachidonic acid to prostaglandins. The non-steroidal anti-inflammatory drugs inhibit the COX-1. So there will be decreased prostaglandins and increased leukotriene E4. And we know that leukotrienes mediate allergic reaction with extravasation and angioedema. So there will be hypersensitivity reactions in the lung and in the skin than seen in susceptible individuals when they take non-steroidal anti-inflammatory drugs. An important clinical tip here is that if your patient develops, and we use the non-steroidals in our immunology clinic a lot because of rheumatology clinic especially, if the patient gets angioedema from one of the non-steroidal anti-inflammatory drugs, if this is a non-selective inhibitor of the COX-1 and COX-2, like aspirin, ibuprofen, and many other non-steroidals, then potentially this patient can develop angioedema with other members of this group. So it's better if the patient develops angioedema to shift the patient to a selective COX-2 inhibitor, which are better tolerated by the patient. Another mechanism for mediating mast cell release is autoimmune, whether, as I have mentioned, IgG against the IgE or against its receptor, or by immune complexes. And as we can see in this figure, immunoglobulin G binds either to IgE or binds to the receptor directly. Another mechanism is the immune complex mechanism, and this is seen in patients with autoimmune disease and with type 3 hypersensitivity reactions. What happens? I have simplified the process in this diagram. The immune complexes produced, for example, in patients with hypersensitivity vasculitis, activate the complement, and then this results in the release of the anaphylatoxins, the complement 3A and complement 5A. These act on the mast cell receptors. There are receptors on the surface of mast cells for these anaphylatoxins. This leads to release of the mediators. Of these mediators are the tryptases, and these tryptases can themselves activate the complement. So this is some sort of a self-amplifying loop. This is a self-amplifying loop. In this figure here, we can see this is the mast cell. These are the anaphylatoxins, and they have their own receptors on the surface of the mast cells. The end result is extravasation of fluid into the tissue. We will shift now to the bradykinergic angioedema that's mediated by the bradykinin, and this may be either hereditary angioedema, and I will leave all this to Professor Dalia Helmi. I will take only this green part here. The acquired angioedema, bradykinin-mediated angioedema. This may occur with ACE inhibitors, or in that case, the C1 inhibitor, which I've mentioned, this one, C1 inhibitor that checks the kallikrein. If the C1 inhibitor is normal, it's seen with the ACE inhibitors. They have normal C1 inhibitor. But if there is decreased activity or a level of C1 inhibitor, then this is another type of acquired angioedema in which the patient will have anti-C1 inhibitor antibodies, autoantibodies. So remember, now we have mentioned that there may be antibodies to the IgE or its receptor in the mast cell mediated type or histaminergic type, and there are antibodies against the C1 inhibitor in the bradykinin type. This is mostly seen in patients above 40 years of age and those with lymphoproliferative disorders. What happens when a patient takes an ACE inhibitor? The ACE inhibitor, sometimes, not all patients on ACE inhibitors. Sometimes the ACE inhibitors, which we know they inhibit the ACE enzyme, the angiotensin converting enzyme helps degrades the bradykinin into inactive metabolites. So when this enzyme is inhibited, there will be accumulation of bradykinin. What happens when bradykinin accumulates? It will bind to the bradykinin 2 receptor, causing vasodilatation and increased permeability. And it binds also to the bradykinin 1 receptor. And this is the cause of the pain that patients with angioedema experience. As we mentioned, and I just to remind you that the bradykinin type, the patients do not have urticaria because they do not have histamine. This angiotensin converting enzyme inhibitor mediated angioedema has a class effect, which means that most of them will have the same effect in the patient. So you shouldn't change from one type to another. It occurs in 0.1 to 0.7% of patients on ACE inhibitors, and it's highest in the first 30 days of starting the treatment, but may be delayed for many years. If the patient develops angioedema, he might have a recurrent attack of angioedema on the ACE inhibitor after within 10 months.
في مشكلة في الصوت؟
اتقطع عندي.
اتقطع تماما باشمهندس عاصم.
مع حضرتك هو النت عند دكتوره زينب بس يعني المهنج عندها شويه.
عند دكتوره زينب؟
يا فندم.
الكونكشن عند دكتوره زينب في مشكله بس.
دكتوره شيرين بعد اذنك النت قطع عند دكتوره زينب فهي بتحاول تدخل تاني.
طيب ولا
فلو في اي discussion او questions already في questions answers.
احنا ما عندناش غير ما عندناش حاجه sound is low، ما فيش حاجه، ما فيش questions لسه so far، وبعدين دكتوره زينب مش سامعانا.
طب هل to proceed with the next talk وبعدين تبقى دكتوره زينب تكمل؟
هتخش ولا لا؟ عشان بس يعني هنستنى
شويه. هتصل انا بيها، هتصل.
الدكتوره زينب
تمام كده؟ صوتي مسموع كده وكله تمام؟
اتفضلي يا دكتور.
معلش النت للاسف الشديد طبعا عادي يعني، الحمد لله انها صبرت عليا النت لحد دلوقتي. تمام كده؟ هنرجع تاني نتكلم على الاس inhibitor induced angioedema. And in this type, there's a study has been done in 2020 in Baltimore in USA. And this study found that the risk factors for ACE inhibitor induced angioedema is more in African Americans. It's 5 times more common in African Americans. In patients on immunosuppressants, it's more liable to occur in older age and those who are smoking. عصيان
المشكلة ثاني.
تمام كده. So also this same study found that half of the angioedema patients who presented over 4.5 years period of the study, half of the cases of angioedema that have been admitted to the hospital were cases of ACE inhibitor induced angioedema. So it's common. The risperidone also produces angioedema, and I mentioned this drug here because we use risperidone in patients with psychosis with lupus cerebritis. So just to be aware that angioedema may occur with this drug. Also, there are case reports of angioedema with rituximab, and we use this biologic often especially in oncology. The bed bugs, infestation with bed bugs can cause angioedema, and the use of hair dyes also. All these can, the bed bugs and the hair dye, act through allergic mechanisms. These are just case reports. And this lady here developed angioedema, and when they searched for the cause, they found that it is the mite. And they, in a cross-section, they found the mite in the histopathological tissue from this patient. The Gleich syndrome, this is a rare syndrome in which the patient suffers episodic attacks every 3 to 4 weeks of angioedema, eosinophilia, urticaria, and it resolves all by itself. It doesn't need treatment. They found that these patients have cyclic elevations of interleukins. And this is reminiscent, this cyclic eosinophilia is reminiscent of cyclic neutropenia and cyclic thrombocytopenia. Our colleagues in hematology know all this. Sometimes some scientists consider this syndrome to be one of the idiopathic hypereosinophilic syndromes. So now I will mention how common is the angioedema. Angioedema in general, I'm not talking only on the hereditary, I'm talking about angioedema in general. It's not a rare disorder, and it affects adults and children. Maybe it's the second cause for acute allergic disorder presentation to the emergency department. So it's second to bronchial asthma as a cause of hospitalization in New York State, as mentioned here. And it's a fatal condition. Sometimes it's fatal because of the laryngeal edema, the pharyngeal edema, or the tongue swelling. Angioedema accounts for 80 to 100,000 emergency department visits. And the hospitalization rate for angioedema is 4 per 100,000 population. Most common of the angioedema is the allergic type. The hereditary angioedema affects 1 in 10,000 to 1 in 50,000 individuals, and the ACE inhibitors epidemiologically occurs in 4 to 8% of the patients. This figure here shows the frequency, and it takes a descending order from left to right. The allergic is the most common. Those idiopathic types are less. ACE inhibitors come next. Up to 30% of emergency department visits of angioedema are due to ACE inhibitor. And lastly, the hereditary angioedema. This is my last slide, which is the angioedema mimickers or pseudo-angioedema. Sometimes the patient presents with a picture similar to angioedema, but he doesn't have angioedema. Like, for example, this patient had this swelling of the eyelids. There is extensive erythema here, as you can see. This is inflammation of the eyelids. This is cellulitis occurring in this patient. A patient may present with edema of the lips as this one, but if you examine him meticulously, you can find here, as you can see, the livid reticularis rash, and here over the upper eyelid, the heliotrope sign. There are ischemic areas in the skin. The patient has weak muscles. This was a case of dermatomyositis. This is one of our patients. Hypothyroidism, of course, leads also to non-pitting edema, so you shouldn't mix it with angioedema. Patients with the superior vena cava syndrome, they have edema of the eyes and of the face. And if you look at the upper chest, you will find dilated veins, abnormally visible veins in the upper chest, in the arms, in the neck, and on the cheek here. Patients may have laryngeal edema from other causes, such, for example, peritonsillar abscess or foreign body, pharyngeal foreign body. So my message is that whenever you are encounter a patient with angioedema, do not just treat the acute attack. Please refer this patient to an allergist or just dig into the history and examine the patient in order to try to identify the type of angioedema and the trigger for this angioedema. This will help you choose for your patient the proper treatment. And thank you.
Thank you, Professor Dr. Zainab Awad, for this very nice presentation concerning the epidemiology and the classification of hereditary angioedema or angioedema in general. And now we'll move to